Great. Well, thank you for joining us here online to discuss care transitions. And we'll be speaking with you today about care transitions, how to improve care transitions, working with teams, going over a lot of evidence base, things that we do at Mount Sinai. Um, and look forward to talking about this. So, here with me today, I'm Jeffrey Farber. I've been the director of our mobile acute care for the elderly service in the hospital since we started that in 2007. I'm a geriatrician, an internist, and a hospitalist. With me today are Sapina Kirpalani, who's our nurse practitioner and nurse coordinator on the mobile A service, and Annie Kleiman, our social worker on the service as well. Okay, so during this module, what we hope to do is teach some very useful, specific, action-oriented discharge planning strategies that you can implement immediately in your own clinical care for older adults that we feel are associated with high-quality transitional care. We'll talk about how to really use an interdisciplinary team most efficiently to affect the best discharge plan possible. And we'll go over some specific communication skills that, again, you can take back and use immediately and implement in your own discharge planning processes that are very useful, especially for more complex discharge plans. So a little bit about the outline first. We'll go over some definitions of what is transitional care, why it's so important now that there's such a focus and an increasingly appropriate, we feel, focus on transitional care. Talk about team-based care and the continuum in the discharge planning process, current evidence for different strategies that are being used, and we'll talk to you about our own experiences at Mount Sinai. We'll do a lot of work through a case study to highlight many of these points, and then wrap up with some take-home points. So first off, as definitions, transitional care is a set of actions that's designed to ensure a lot of C's, okay? Coordination, continuity, of care for patients that are going from one location to another. It could be within the same facility or from one location to another in different facilities. The keys are that this encompasses both sending and receiving information about the transfer, and it's not just the patient, right? And everything that we do in geriatrics and as well with complex care planning needs are the patient and caregivers, whoever that may be, involved with the patient being prepared. There are some references on the slide you'll see from position statements from the American Geriatric Society for further information, and there's a consensus policy statement on transitions of care from most of the large major national organizations involved in healthcare for older adults. So this slide highlights the point that discharge planning is not a discrete activity that'll happen at a certain time during the patient's admission. It's really part of a continuum that has to be thought about on admission, constantly revisited throughout the hospitalization, and then completed upon discharge. And it's also not something that's done by any one individual. It's really a team-based function that spans the continuum from admission through discharge. So some of the keys here in thinking about hospitalization as a continuum are to really think upon it on admission. One thing I encourage the house staff and the fellows and med students in training to do is to add discharge planning to their problem list from day one. So when they're going through problem-based charting and addressing all of the patient's needs and concerns during the hospital stay, in addition, they need to anticipate discharge. Think about what potential discharge needs there might be. Already on admission, you sometimes have clues to barriers that might be present that would impede that potential discharge plan. And of course, be flexible in adjusting what you think a patient may benefit from on admission during the hospital stay because care needs change as the patient's clinical status will change during the hospitalization. In terms of team-based care, it's very important to accept ownership of this problem. A lot of clinicians, especially physicians, historically have not really taken an interest in discharge planning and care transitions. It's generally considered just not as intellectually exciting and attractive as the admissions that are coming at the same time, where you're more doing diagnostic workups, figuring things out, ordering tests, and playing detective a little bit. Whereas discharge planning, it's sort of like you've been there and done that, and so let's just move on. That's not going to work. And what we want to go over in this next hour is really talking about why it's so important to focus on discharge planning and taking ownership of the problem. Also, it can't be done alone, as I mentioned. There are multiple peoples, from nursing, social work, physician staff, physical therapy, often occupational therapy, case managers that are involved in discharge planning. And don't forget and lose sight that the patient and the caregiver team, they're really at the head of the team. You can have a wonderful, intricate, complex discharge plan organized that you're very excited about. It sounds wonderful. But if the patient and the caregiver are not on board, or for some reason it's not what they want or won't work for them, it will fail. Avoid overlapping or work duplication, so that's about using teams efficiently, which we'll talk about. And communication, even though it's at the bottom of the slide, is really the most necessary component to any effective discharge plan. Most fail because of some error or lack in communication. Okay, I'm going to hand this over to Sapina now, who's going to present a case to highlight some of the most important points.
Okay, so I will be discussing a case of readmission. This is a case of a 78-year-old female who's on Coumadin for atrial fibrillation. She presents to the emergency room with spontaneous right ear bleeding. In the emergency room, she is evaluated and found to have no active bleeding. However, her international normalized ratio is 9.6 supratherapeutic. The normal is between 2 to 3. She normally gets her INR checked with her cardiologist, and upon her last check, it was within the normal range 3 weeks ago. Spoke with the cardiologist. Her last INR upon discharge was 3.2, and records indicated that she was instructed to take Coumadin 2 milligrams nightly with the next follow-up in 3 weeks. When asked, patient said she took whatever dose was prescribed religiously every morning and night. Her past medical history is significant for hypothyroidism, CHF class 3, AFib on anticoagulation, hyperlipidemia, and hypertension. Cognitive status. Her mini-mental score from chart review reveals 18 out of 30, indicative of moderate dementia. Her functional status. At baseline, she lives alone, ambulates with a walker, is independent with ADLs, and reports she manages her own medications. Her social support includes a daughter who lives nearby, is involved in her care, and assists with IADLs. Her physical exam is unremarkable. Hospital course. For her elevated INR, patient was treated with 4 units of fresh frozen plasma to reverse the effects of Coumadin. She was discharged on Coumadin 2 milligrams daily with a follow-up next week with the cardiologist and an INR check at that visit. We communicated with the cardiologist and confirmed that patient was only to take Coumadin 2 milligrams nightly and never in the morning. But it seems patient had difficulty following instructions, lives alone, and suffers from moderate dementia, and began taking 2 milligrams twice a day following previous discharge. We think her INR was elevated because she was taking double her dose and didn't understand and remember directions. She had no further evidence of bleeding, and her hemoglobin remained stable. So at this admission, the discharge plan included involving the family early on. The family meeting included discussions regarding risks and benefits of anticoagulation given patients' dementia, risk for future bleeding, proper dosage of Coumadin, and monitoring, and likely cause of readmission. Patient's family was involved in decisions regarding need for additional home care services, and we elicited patient and family's preferences. In regards to medication management, we communicated with patient's daughter regarding all discharge medications, provided education regarding indication for each medication, dose, and any adverse effects. Follow-up included having a set appointment with the PCP and the cardiologist within 1 week of discharge. We discussed with patient's cardiologist to communicate results to the primary care provider as well as family to ensure proper Coumadin therapy management. Determination was made that INR tests should be done weekly, not once every 3 weeks. Plan to initiate home lab monitoring services given patient is an elderly, lives alone, and requires transportation setup for appointments. We also included a plan to have a post-discharge follow-up phone call within 24 to 48 hours upon discharge to answer and clarify any questions that come up when patient arrives home. Transfer of information included communication by the inpatient geriatric team with patient's cardiologist and PCP regarding plan for discharge, including discharge medications, lab monitoring, and follow-up. Discharge summary via electronic medical records within 24 hours, referral to home care services for medication management and additional home care services. So some of the red flag issues that we spot in the prior discharge from the first admission include lack of caregiver involvement, lack of assessment of patient's baseline cognitive and functional status, lack of psychosocial assessment and home care needs, lack of patient and family education regarding discharge medications, follow-up, and red flag signs and symptoms. Poor communication with the cardiologist upon initial admission regarding prior difficulty with instructions. Poor transfer of information. The cardiologist did not inform of any prior difficulty following instructions. And the follow-up appointment was set too far in advance, 3 weeks. So is there a science behind the art of discharge planning? We seem to think so. There are 4 main domains of discharge planning. The first one is patient and caregiver preparedness and self-management support. The second, medication management. Third, follow-up. And fourth, transfer of information such as discharge summaries. My colleague here, Andy Kleinman, will address the first domain of discharge planning.
Okay, when we talk about discharge planning, we always have to consider how the patient and the caregiver will feel and how they'll manage once outside of the hospital. Often we find that in the hospital, the patient and caregiver really feel unprepared for the next step. They're not ready for discharge just yet. That the transfer of information is lacking. Perhaps their primary care physician hasn't been involved while they're in the hospital and may not know what to do once the patient's at home and has a problem. Sometimes they feel they haven't expressed their preferences. We're suggesting they go to rehab, but they really want to go home, or they need home care services but haven't told us that, and they're unsure of how to manage their disease. We may have instructed them how to do Lovenox or insulin, but they don't really feel that they can manage that confidently once they're at home. On the hospital side, the things that contribute to these feelings on the side of the patient and the caregiver are that we inaccurately assess the patient's functional status. They were walking at home before they came to the hospital, so we send them home assuming that they're able to ambulate again once they get home. And we overestimate their knowledge of required self-care activities. Again, we may have instructed them how to do certain medications and care for themselves at home, but they're not really able to do that on their own. Some of the issues that contribute to the patient feeling uncertain about their discharge are that while they're in the hospital, there's been a change in their ADL or IADL functioning. Just by lying in bed for a few days, they've become so weak that they can't walk as well as they were prior to their admission. Who does the actual care at home? Some of our patients are the caregivers at home, and they don't have someone who's able to take care of them. Poor understanding of medical problems, they may have a low health literacy, and false expectations regarding symptom improvement or unrecognized red flags. They're being discharged, so they feel their symptoms are all better, but often those symptoms take time to improve, and they may not recognize when something actually does go wrong at home. On the hospital side, we as a team often have ineffective physician-patient communication. We haven't taken the time to really make sure that the patient understands and is comfortable with the discharge plan. So some strategies we have to improve the confidence in discharge planning and plan for better outcomes is that we use early, individualized, interdisciplinary discharge planning that involves both the patient and the caregiver. We always meet early to assess what existing resources the patient has at home, what they prefer upon discharge, what they feel they will need in order to go home safely, and follow up with their treatment plan. We try to anticipate early where they will go for discharge. Do they need to go to rehab, or can they go home? And are there any new needs? Can we have a physical therapist evaluate them early on to assess how safe they are walking? Maybe they have a flight of stairs in their home and they can't manage that on their own. Do they need any equipment, a hospital bed, a wheelchair, a walker? We can order that early before the patient gets home to make sure they're prepared once they are at home. Early inpatient education, we can order a nutritionist consult, teach them about their diabetes, diet management, and inpatient supervision for new techniques. Make sure that they're able to do any injections that we're prescribing them. Additional strategies are standardized audiovisual instructions, written instructions, brochures focusing on self-management. There's so many resources on the internet. We can print that for the patient and review it for them so they can have something to take home with them. And of course, improving physician communication skills is key. Avoiding yes/no questions. Make sure the patient is able to verbalize how they're feeling. Ask them what questions they have for us. Avoid the teach-back. Using the teach-back method, can the patient repeat what we've said to them? Avoid medical jargon. Make it simple for the patients to understand, using interpreters when appropriate. And start teaching key information early on at the admission, making sure that throughout the treatment process, the patient understands their treatment plan, and providing written information identifying the members of the team and our contact information. The MACE team, we give out a brochure to all of our patients that has pictures identifying each one of us, our roles, and our phone numbers. The next domain is medication management, and I'll pass that back to Sapina.
So medication management is a very crucial step in ensuring smooth transitions of care. Educating patients' families, caregivers, and caregivers regarding medication management, empowering them in self-management skills is the key to better patient-centered outcomes and will result in decrease in medication-related errors. Some of the facts regarding medication management include 49% of hospitalized patients experience at least one medical error in medication continuity, diagnostic workup, or test follow-up. Errors during ordering of admissions and discharge medications make up 50% of medication-related errors. Med reconciliation during discharge is a process of comparing a patient's medication orders to all the medications that the patient has been taking. Med reconciliation should be done at every transition of care in which new medications are ordered or existing medications are rewritten, such as changes in setting, service, practitioner, or level of care. In regards to medication management, always obtain a complete medication history by asking the patient about medications taken at different times of the days, dosages, length of therapy, medication prescribed by different physicians, over-the-counter products, allergies, and adherence. Compare and reconcile medication information obtained from patients, caregivers, prescription bottles, medical records, pharmacy records, and primary care providers. The key is to display pre-admission medication list prominently in the chart, reconcile medications during all transitions, including at admission, intra-hospital transfers, and at discharge. Communicate complete and accurate medication information to the next provider at discharge, including indications for any new medications or reason for any changes. In terms of medication management, some of the general strategies include it's a continuum, it's a dynamic process, it's one of the core measures, and it's an opportunity to review, simplify, and educate patients regarding their medication management. When it comes to medication management, one specific strategy that seems to be effective is having a clearly designated person inside the team. In a journal in the Archives of Internal Medicine, the study found 30 days post-discharge, preventable adverse drug events were decreased from 11% to 1% in an intervention study when a pharmacist performed medication reconciliation at discharge. When it comes to medications, think out of the box, be practical, especially when discharging patients on late Fridays and on the weekends. Keep in mind if you're discharging patients on certain medications such as antibiotics, anticoagulation therapies, pain medications, to check with the pharmacy prior to discharge to ensure that the medication would be available, would be covered by insurance. Keeping in mind if the medication you're discharging the patients home with are going to require any sort of monitoring levels such as Coumadin or Lovenox therapy, insulin therapy, and always refer appropriately to home care services for nurse medication management programs. The third domain of discharge planning, follow-up. Questions don't arise until patients are home. There might be questions or concerns regarding continuity of home care services, malfunction of equipment. They might be concerned regarding clinical recovery, new medications, adverse reactions, and concerns regarding continuity of care with their primary care providers, follow-up, and specialists. One single strategy that seems to be effective in regards to follow-up is giving a patient a set follow-up appointment at the time of discharge within 1 to 2 weeks with their primary care provider. Some other strategies that seem to be effective are hospital-staffed follow-up clinics, follow-up phone calls, and follow-up home visits. All these strategies seem to increase patient satisfaction, increase medication adherence, and prevent readmissions. The next two slides will touch upon two transitional care models. The first one is the Advanced Practice Nurse Transitional Care Model by Dr. Naylor. It targets cognitively intact older adults with multiple comorbidities. Advanced Practice Nurse in this model sees the patient in the hospital, designs a follow-up plan with coordination with the inpatient interdisciplinary team, implements the plan, and makes home visits, is available 7 days a week through telephone, phone calls. Follow-up continues through the expected recovery, and the results show increased patient satisfaction, reduced rehospitalizations, and decreased hospital costs. The second model, the Care Transitions Intervention Model by Dr. Eric Coleman, involves integration of 4 pillars of transitional care. These are medication management, personal health record, red flags, and follow-up. The transitional coach encourages the patient and empowers them to play a more active role in self-management of their chronic medical conditions. Patient is visited in the hospital, at home, and through telephone phone calls. The results show lower readmission rates and lower hospital costs. The last domain of discharge planning is transfer of information, including discharge summaries. My colleague, Dr. Farber, will address this domain.
Great, thank you, Sapina. Before I go on here, let me just make a couple points about things that have been said and ask you to think about something. So here, you've probably heard this quite a bit during discharge processes on the day of discharge or at times when you're interacting with patients and you want to leave. So you say, okay, do you have any questions? All right, think for a second about what's wrong with that. And the answer is that that's a very poorly worded, closed-ended question. And older adults are overwhelmingly going to answer what? No. Right. They're going to say no. Okay? And that's because despite popular opinion that thinks that older people tend to complain a lot about their problems and over-report their symptoms, studies have consistently shown that older adults, in fact, underreport their symptoms in comparison to younger patients. And they're more likely to say no to these closed-ended questions. They don't want to bother you. They don't want to take up more of your time. They feel a larger amount of respect for the care team, especially the physician on the care team, and they just want to please. And so poorly worded questions will get you poor answers. A much better way to ask would be what? Okay, think about that. Instead of asking, do you have any questions? An open-ended way to ask that question would be, what questions do you have? Or, what else can I explain better? And in addition to that, what Annie had mentioned earlier would be, doing the teach back. It's a great time to go and do the teach back and say, tell me what you plan to do when you go home with regards to medicines. Or tell me what the plan is for follow-up once you go home. And have this conversation and engage patients so they actually have to demonstrate understanding of the information. And without doing that, we're really at a loss and don't know what's happening and in all likelihood haven't done a great job of communicating. So just a couple pearls that I thought I'd throw in there. And we'll move on now to the last domain in transitional care, which is discharge summaries. Like I mentioned earlier, the main problem, you can probably guess, is that they're just not done well. They're not done consistently, and they're not done well. And that's largely a product of, as I mentioned earlier, an overall lack of interest in this subject. There's no training in this. The people that are generally doing this in the hospital are house staff who are busy doing lots of other things and haven't received training. And if you don't have training, that tells the trainee that it's not important, and it also makes it hard for them to do it well. And so that's really the state of the facts. Sort of sad, but don't worry, we'll get better. Okay? So some of the studies have shown, like I mentioned, the poor availability, that really only 1/3 of the time in this study of primary care physicians did they say they actually, always have the discharge summary when they see their patient for the post-discharge office visit. Other studies have shown the availability of that discharge summary at the first visit to be as low as 12 to 33%, and even a month later, it's oftentimes just not there. So that's the availability problem. The other problem is when it is there, the discharge summaries don't have a lot of the information that you would expect a good discharge summary to have. That includes, important test results. What happened during the hospital stay? What medications is the patient supposed to be taking? Are there any results that are pending that I'm supposed to follow up that haven't come back by the time this was written and the patient was discharged? Were there any counseling done about anything? Were there any new diagnoses that were developed, identified during the hospitalization? And what are the follow-up plans? What do we do from here? As we know, when patients leave the hospital, they're nearly never back to where they were before they had the illness that provoked the hospitalization, and the care plan and the treatment needs have not been completed. Only a part of them have been completed, the most acute parts, which would require a hospital stay, but there's a lot that needs to be done with this episode of care just outside the hospital setting. Okay, and that's all the information that needs to be in these discharge summaries. So how do we improve the timeliness? Well, there's a few studies that have shown that computer-generated discharge summaries are better. And actually empowering and giving patients their discharge summaries increases the likelihood that doctors on the follow-up visit will have it available. Okay, so you can actually, if you put together a process where discharge summaries are done at the time of discharge, given to patients as part of their discharge process, then they're likely to bring it to the PCP office instead of saying, well, I'll get to it later and I'll fax it or I'll mail it or I'll scan it and email it or whatever to the PCP. Okay, so hand delivery by patients decrease the time to receive, and more of them were likely to get it when it was computer generated versus something that happens later, either handwriting or dictated or something like that. Fortunately, with the move towards adopting electronic health records and the federal stimulus dollars to encourage physician practices and hospitals to use electronic health records, we'll be seeing much more electronic discharge summaries with here's the evidence showing that why they're better than not. So what about quality? I mentioned that even if you have one, if it doesn't have information that's useful to the PCP, it's not of much value. It's hard to know. The studies have different quality indicators. It's hard to really generalize at this point what statistical significance you could draw from them. But we know that there are certainly areas of improvement in some studies that have been done looking at different types of ways to improve the quality. These are the template, the brief communique, and then teaching interventions, which I'll go through now. So templates increase the quality and the efficiency of the information transfer. Been a couple studies looking at PCP satisfaction with the discharge summaries that they get and how templates improve that. Okay, so they feel they're getting higher quality material. Electronic medical records, again, allow for this to happen much more complete and more readily. And the big question remains about what should be included. Okay? And if it's not standardized, the template, then it's seriously lacking. And a big opportunity to improve it would be to simply standardize that. Okay? Here are some of the things that really should be standardized, and the Joint Commission has come out with recommendations to support this. Okay? So this is what should be in a discharge summary according to the Joint Commission on the Accreditation of Healthcare Organizations. The diagnosis, right? What is it that brought this patient to the hospital? Physical findings that were important. You don't have to go through every body system and read your admission physical exam findings, but you have to call what was important that was abnormal. Same thing with test results. You do not need to provide, every test that was done in the hospital, but what test results were important. Okay? Discharge medicines has to be clear, every single medicine. And of course, the route and the dose and the frequency and the duration. Follow-up and appointments, right? So what is the plan? Like I mentioned earlier, something that you need to provide to patients, and then during the feedback technique, ask them what that is, what counseling was done, and of course, what tests are still pending. The last item is increasingly common given the push to make hospitalization shorter and shorter because of our reimbursement system, that many tests are done, but the results are not back, or the final reports are not back and available at the time of discharge. The brief communique, something we actually still use. We're trying to get away from it in favor of an electronic discharge summary, but until we're very comfortable that the electronic discharge summary contains all of this information that we discussed in the last slide, we're still using this technique. What it is a very quick, more abbreviated discharge summary that is often an email to the PCP, perhaps a fax, even a telephone call that has this information. What's the discharge diagnosis, right? So patient with pneumonia. What are the medications? Okay. Any test results that are important? Let's say the sodium level remains sort of low, right? So they'll tell you what that is. Follow up, so they're coming to see Dr. Smith next week, Thursday at 10 a.m., and really a suggestion for what to do next. I would continue to hold this medicine, and when they come see you, repeat the chemistry study so you can follow up on that sodium level. If it's normal, then I would reintroduce this medicine. As detailed as possible like that is really what the PCPs need, because they're often not involved and privy to what happened with their patient during the hospitalization. Teaching interventions, finally. You can teach house staff and other folks that are doing discharge summaries how to do them, and this will improve the quality. One of the best things, actually, is feedback. The same technique we talked about earlier for patients, but we will take discharge summaries and then bring them to the writer, often the house staff, and review it with the house staff in light of the JCO recommendation of included items, and show where it may fall short. That's the most powerful way to affect change, because if you ask, and studies that have asked doctors, I do them great, I include everything, sure, that makes sense, I do that. When you actually show the person that that's not the case, it has a much more powerful impact on affecting change. And that's something that we did here at Mount Sinai in our geriatrics department with the geriatric fellows, which did show a significant improvement in the overall completeness of the discharge summaries. Okay, so we're going to move now to our experience, and does this really work? Let's talk about our mobile ACE service, which basically integrates available data in the transitional care, uses the interdisciplinary team, which we'll talk a little bit about, and very importantly, builds in a continuous quality improvement process so that we can always do better. And that's the thing, of course, in healthcare, that there's always room to continue to do better. I'll turn this over to Annie now to talk more about our mobile ACE service.
So our mobile acute care for the elderly service basically replaces an ACE unit, a geriatric unit. We no longer have a geriatric unit, but rather our mobile team. And our patients come from two different sources. We primarily see patients who are known to our outpatient geriatric center, the Martha Stewart Center for Living, and we also follow patients who are admitted from one of the nursing homes on the Upper West Side. Our team has 4 members: a geriatric attending, a geriatric fellow, a nurse practitioner, and a social worker. And we really work together and collaborate throughout the day towards our patients' treatment. But our roles also overlap, and I'll discuss each one of our roles briefly. The geriatric nurse practitioner is really most responsible for being the hospital coach, educating the patient and the caregiver, coordinating the care within the hospital, getting tests done, and also doing the follow-up phone calls, making sure that once the patient is home that everything is okay, and answering any questions that they have. The social worker does the complete psychosocial assessment upon discharge and anticipating any barriers or needs towards discharge, and really coordinating all the discharge planning, setting up the home care, facilitating nursing visits, or if the patient's going to a nursing home, any rehab. The attending and the fellow are most responsible for managing the medical care of the patient while they're in the hospital. And we also always assure to have a family meeting early on in the hospitalization, which the attending and the fellow will lead. Our team meets every morning at 9 a.m. To have an interdisciplinary meeting. We focus on discharge planning, and we each bring our knowledge of the patient and the treatment plan to focus on what we can anticipate the patient will need for discharge. We see the patients together, and we try to always introduce ourselves to the family at the same time so that the patient and the family see us as a team and can approach each one of us as part of a team. And we also try to do an afternoon huddle to review the day's work and discuss what needs to be done for the next day. So we really coordinate together and collaborate in an interdisciplinary function, and making sure that all the patient's needs are met together.
Great, thank you, Annie. So now I'm going to wrap up by discussing some of the research that we've done on this model. Most significantly, a paper that we published in the summer of 2011 in the Journal of Hospital Medicine about our operational and quality outcomes for the care that we provide for our patients on the mobile ACE service. As Annie mentioned, in 2007, we significantly changed our care model and moved from a geographic unit-based model, which many listeners may be familiar with, which we had as well, dating back to the early 90s, largely because of increased hospital occupancy. We found that really only half the time did our patients get a bed on our ACE unit because it was full, and so they had to be placed in a bed elsewhere. And if you looked at the ACE unit census on any given day, about half of the patients you would find were not ACE unit patients. They were also overflow from when other units were full. So in the era of high hospital occupancy rates, which we feel for the foreseeable future will not go away, it was just practically difficult for us to continue this model. Switching to the mobile ACE really allows us, one, to get exercise during the day, because we're always on the move and going to where patients are, which is good for our waistlines. But also, it allows us to geriatricize the institution. And quite frankly, instead of focusing on high-quality clinical care for older adults, that's patient-centered and interdisciplinary on a very small number of patients. We have 1,100 beds in our hospital, and 30-bed unit to provide outstanding geriatrics care is great for those 30 patients. But what about the other several hundred who could benefit? So by going mobile, we also are able to work with a larger number of patients and influence the care provided by other caregivers outside of our immediate team on the different medical floors. So that's what we did back in July 2007. And the study referenced on the bottom, you could look for more details, but I'll go over in the next couple slides basically what we found. In terms of who our patients are, like Andy mentioned, they're largely community-dwelling older adults that get their primary care from our outpatient geriatrics academic practice. They're quite old, with an average age of 83. They're largely three-quarters female, which is common at most practices at that age. The marital status was very varied, and the comorbidity index was roughly 2.5 and was similar across all comparison groups. So what we did was we took our patients who were cared for by our mobile ACE service in the first year of operation, and we compared them to ACE unit patients from the year before. Then we also compared them to patients who were admitted by other medical teams in our hospital with the same problem, the same diagnosis-related group called DRG, the same severity of illness score, and we matched them with age and gender and zip code. And we saw that the baseline characteristics, as this slide shows you, there's no significant differences. So they're very similar patients. And then what did we find? Well, in short, we found a very significant reduction in length of stay. If you look at the first comparison, where we looked at the first year of MACE compared to the previous year, we had a 5.8 adjusted length of stay compared to a 7.9 adjusted length of stay. In year one, the reduction in length of stay was not significant, but in year two, it was. Oftentimes with any program, when you roll it out, there is a learning curve, of course, and that's what we attribute the first year's lack of significance to, as we were getting used to this model, and in large part also transitioning to a hospitalist-based model, where the attending geriatricians would be a smaller group with higher expertise in hospital care, as opposed to 12 or 13 different geriatricians just doing a 4-week stint on the service. Total costs also were significantly reduced. You see 10,000 versus 13,000 basically for the MACE and the ACE, and by year two, that difference was 10,700 versus over 15,000 for patients in the control group. If you break down the costs, which we do, you'll see there's lower direct nursing and pharmacy costs for all of these comparisons, except for pharmacy in year one, in which the difference was not significant. In terms of the quality, we looked at mortality and 30-day readmission rates, and they were the same throughout all comparisons. We had hoped, of course, that the 30-day readmission would be lower, but in fact it wasn't. I'll talk a little bit about that on the take-home points on the next slide. So what we hope you'll take home from this time spent listening to this module is that hospitalization is really part of the continuum. And we, as hospital care clinicians, need to remember that even the continuum from admission to discharge, thinking about discharge planning is important, but it's larger than that. It's how the patient was functioning and within what environment and with what types of supports before they got sick and came to the hospital, and what's going to happen afterwards as well, that type of continuum. Team-based care, we hope we've demonstrated, is really the optimal way to affect the highest quality discharge planning. Medication reconciliation, follow-up phone calls, which is something we do for all of our patients within 24, 48 hours, and set appointments before discharge. We're actually moving closer to 1 week more often now than 2 weeks, depending on the acuity and the need for quick follow-up. That seems to be all effective strategies for improving discharge planning. And teach back is one of the most powerful communication skills you can take home, adopt, and start using immediately in your experiences with patients, and has been shown to really improve the discharge planning process. And last but not least, don't forget, this is not rocket science. This can be done. We can all do this, but not alone. This is really a team effort. So thank you very much for your attention, and congratulations on completion of this module.